My name is Pitchyaiah, and along with Shiva Balasubramanium, Ms. Azadeh Wickham, Mr. Vincent Staggs, and Dr. John Gatti, our project evaluated the use of bladder irrigation as a treatment as it relates to bladder colonization and urinary tract infections in children on clean intermittent catheterization, also known as CIC. Now, CIC is one of the main treatments for those with a neurogenic bladder. However, patients on CIC are predisposed to colonization with asymptomatic bacteria in the urine. While many well-meaning practitioners try to identify this bacteria and attempt to sterilize the urine, asymptomatic bacteriuria, also known as ASB, is found in over 70% of patients with neurogenic bladder who perform CIC. And though the American Academy of Pediatrics provides recommendations for those with a positive urine culture with over 50,000 colony-forming units for catheterized specimens, if there are symptoms present, this definition is extremely nonspecific, and there's no recommendations for bacteria that's due to simply colonization. And colonization not only increases the risk of developing a UTI, it also reduces the reliability for our tests for UTIs. In a recent study performed at Children's Mercy, 98% of 272 patients seen in the ED or urgent care settings were being overtreated with at least one round of antibiotics for asymptomatic bacteriuria. And this causes resistance, and we've been seeing an increasing trend in resistance. Bladder irrigations can be done in several different ways. It can be used using sterile water, normal saline, or Neosporin. So in terms of our methods, we did a retrospective chart review over a 3-year period in patients who were 21 and younger and who had had a diagnosis of urinary tract infections and neurogenic bladder who were participating in clean intermittent catheterization. We collected demographics, urological surgery history, urinalysis, culture results, and bladder irrigation type. And based on the length of time of each period, we computed the rate of UTI per patient per year for each irrigation condition and for post-surgery versus not post-surgery. In terms of our results, we identified 169 patients. There were slightly more males, 58%, and the median age was 9.4, and 70% were identified as white. UTI rates were modeled as a function of both irrigation type and post-surgery status by fitting a negative binomial model with UTI count as the outcome variable and patient days as an exposure variable. In terms of significant results, we found that UTI rates were estimated to be about 2.23 times higher with water irrigation than with no irrigation. The p-value was 0.062, and that UTI rates was 2.36 times higher post-surgery when we controlled for irrigation type. There was some evidence of higher efficacy of Neosporin irrigation over water, but the estimation was too imprecise to rule out an effect in either direction. So in conclusion, patients on bladder irrigation programs were more likely to have UTIs when compared to those not on an irrigation program. And a history of surgery was also a risk factor for UTIs. And although these findings appear to be counterintuitive, there's a simple explanation. Patients who are at a higher risk for UTIs, including after their relevant surgery, are more likely to have irrigation prescribed. This likely reflects a treatment bias, where bladder irrigations and surgical interventions are more common in patients at a higher risk of UTI, therefore correlating with the odds of a UTI. Therefore, in identifying this vulnerable set of patients with neurogenic bladder, it allows us to look at future studies that compare the efficacy of treatment for those who are specifically predisposed to UTIs. It's hard to blame practitioners for wanting to treat their patients, but we do need to come together with better guidelines on what makes up ASB and how to manage these patients so that we don't increase the resistance of these urinary tract infections.